In this session, one is very boring, the other two are very exciting. The one that is very boring, unfortunately, is mine. So I need to thank Professor Abed Aleibi for this invitation, for this very nice course, and for this collaboration. He is the one who looked for ESGE in the first place to collaborate. Of course, the second speaker, Professor Bandari, is the real bridge of ESGE with Middle East, and we really hope that in the next future we can do much more than we did in the past. Why we decided to talk about innovation? Because endoscopy is innovation. Endoscopy without innovation is dead. And somewhat innovation by our medtech companies also push a lot our research, as we will see. This is just the exponential rocket of innovation in endoscopy. I know that you can have this slide also for artificial intelligence, but I believe more in this real intelligence evolution than in artificial intelligence evolution. The problem of the innovation in endoscopy is that very unlikely in my life, I have seen that we had a clear problem, and then we developed the innovation that was against this problem. I always had the feeling, maybe I'm wrong, that actually it is the opposite. There is some new innovation. It may come from technology, it may come from a computer, it may come from wherever it comes. And then you try to apply this innovation to all the possible problems until, like in Darwinian evolution, one survives and all the other dies. You say, okay, but Cesare, what is the difference in between one paradigm or the other? The problem is that it's very difficult to anticipate what will come in innovation in endoscopy. Everything seems very impulsive, unpredictable, erratic. So I don't trust myself. And so I asked ChatGPT, give me an idea of how innovation in endoscopy evolved in years. You may see that, of course, people like Pradeep, who believed in ESD in 1995, were really pioneer, because actually it evolved very nicely. But then the poem came, then it was bariatric endoscopy, then there is here Andrea and Benny, US biliary drainage came, then it came artificial intelligence, then regenerative endoscopy. From one, it's always very difficult to predict the other. So I feel that if scientific society have one role, this role may be to somewhat validate innovation. But I know that a lot of you argue that scientific society have a role. But if they have a role, maybe one role is to validate the innovation. So the good and the weak of endoscopy is that most of our validation is technical. We mostly talk about technicality, because it is easy, because a company develop the device, they need CE mark approval, they need to do a study, blah, 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 it is a technical validation. Is this technical validation really important? I feel it may be. It may be according to whether the outcome that is selected is reliable. For instance, when Pradeep in 1995 came out with ARSGE for T1 cancer, this was an important technical outcome. Now, if Pradeep come and say, oh, look, Cesare, I have my speed of resection time, I'm not sure it's still so relevant. Of course, it's better for him because he can play tennis, but I don't know if it is good for the patient. So what is important is that outcome is a proxy for a clinical outcome. In fact, you can see access to biliary tree. We were talking with Andrea and Benny with the US biliary access against radiology. It was just a revolution. In fact, the third point that I put is the comparison with other discipline, because Andrea is right. I compare gastroenterology with the radiology approach, and this is relevant. Pradeep compare endoscopy with surgery, and this is relevant, and all of them are compared with oncology. So an outcome should be translatable from one discipline to the others. And this is, in my view, how a scientific society, and this is for Antonio, should approach. So, Antonio, you should tell before what the technical outcomes are important when validating a procedure. So it comes to the robotic ESD. What is the robotic ESD aiming? To R0 resection, to foot thickness suturing, to speed of resection. Of course, some of them are important, some less. This is for benefit and this for harm. Has anyone done this exercise? No. So we start today and we decide one person who does it. Antonio Facciolusso. Okay. And these are some examples. So for instance, this is the meta-analysis that was done to validate the traction. Yesterday, we talked about traction, and at the end, it was mostly validated against procedure time and resection speed. So it was not validated against R0. On the other hand, against R0 was validated the first endoscopic robotic system that was introduced as much as with the speed of resection. It is very difficult to define an outcome for regenerative endoscopy outside the closure of the fistula that comes week later, and it can be done with other reasons. So to define outcome for regenerative endoscopy is definitely a challenge for our scientific society. At this point in our society, there was a lot of argument. How should we publish this technicality that come out from our research? And then we need to pay tribute first to Pradeep, then to Lorenzo, now to Antonio for coming out with the technical document. If you do technical research, the scientific output will be a technical document. And this is one of the technical document that I like the most, the one on point. Why? Because this doesn't tell you whether the patient takes benefit or not. It only tells you how a poem should be done according to the research that was done on the speed of resection, for instance. No? So you need to do pocket. Okay, I don't know if it's more R0, but you need to be pocket to be fast. You need to do tunneling, you need to do hybrid, etc. So this is a technical guideline that comes from technical research that does not address technical outcome. This is, no, the first was on ESD, this is on poem. But this is the first part of innovation, the easy part. Then there are very few articles that, in the story of endoscopy, changed endoscopy and medicine forever. And these are the clinical studies. And clinical studies must be about what medicine is about. So it is about efficacy and safety, and maybe also effectiveness. And here the outcomes are much more easy and much more oncological oriented, metabolic oriented, surgically oriented, and also in terms of safety are associated with important outcomes. So this is the second exercise that we could do, because, for instance, when you validate ESD, something is to have a recurrence of 1 centimeter low-grade dysplasia. Something else is to have a distance metastasis 3 years after an ESD. Something is to have a severe pancreatitis when you do an access to the biliary tree. Something else is to have a delayed bleeding. Something else is to have a delayed perforation. So the problem of clinical validation of endoscopy is a trap. Because what is important is very difficult to achieve. What is easy, most of the time, is irrelevant. So the first case is definitely a neoplastic recurrence, and I will be back on this. But neoplastic recurrence is very easy to achieve, but very irrelevant. A bit more important, delayed perforation. So I'm sorry to say, but the validation of ESD came from recurrence of low-grade dysplasia most of the time. This is the Jeremy Jack paper. This is the ESD TAMIS study that substantially showed that ESD is the technique associated with less benign recurrence. Very easy, but in my view, probably quite irrelevant. Maybe this is the meta-analysis that we did on 4 Japanese trial, and this is one of the 4 trials on clipping after ESD, showing that you reduce substantially the risk of admission for bleeding from 4 to 2%. And in my view, this is quite a relevant outcome because patients don't come to the hospital after an ESD for a bleeding, and it was quite effective. But definitely, and then Pradeep will be much better than me in the next talk, the real challenge for endoscopy is oncological outcome. We want to win on oncology, and this is the totally madness and crazy, because you always need a crazy person to push medicine forward. For instance, Leon Mons is one of these crazy patients. He's really mad about this, and he designed this TESA randomized trial for early high-risk rectal cancer, randomizing in between 3 arms, mesorectal excision, chemotherapy, or only active surveillance. And as you may see, the primary outcome of this trial on rectal cancer was distant metastasis. And actually, active surveillance, so do nothing, had the same risk of distant metastasis, stomach rays, and blah, 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 than any other technique. So basically, you don't need the surgery after removal of a high-risk early cancer. You can just surveil the patient and have a surveilled surgery as soon as this is needed. And this is the final output of the TESA trial that will be published very soon. And this is the similar experience in the Netherlands, where they take all the Barrett high-risk early cancer that did not go to surgery, they follow up, and as you may see, most of the patients with a T1B Barrett cancer did not proceed to distant metastasis, and most of the death that occurred in this population was not related with the cancer. What does it mean? It means that endoscopy can have oncological outcome, that we need to raise our head, we need to look at the oncological horizon, and we need to understand that endoscopy can cure cancer. You don't need surgery after endoscopy. And then I come to our hero. Here is Andrea Anderloni and Benny Madlavillano, who went on gastroenterology with their study on pancreatitis. Because the primary outcome of the study by you, Andrea, is the occurrence of pancreatitis, but there was a lot of argument whether pancreatitis should be a good proxy for validating a technique, because some others said, no, it should be survival for cancer, it should be when you start chemotherapy, but we said no. If pancreatitis was important 20 years ago when you started the ERCP, pancreatitis is important now that we have EUS. And so we force all the scientific community to accept that pancreatitis is a relevant outcome. We cannot change the outcome from 10 years to 10 years only because we don't like the technique. And these are the trials that validated the EUS approach. Of course, it was easy to validate POEM because dysphagia is very easy to object, and dysphagia is a very clinically relevant outcome. This is why probably POEM is one of the most successful example of innovation in endoscopy. And this is all the number of procedures here in Saudi with Abed and here in Germany with Alanna that have been performed. For instance, much more difficult to validate GPOEM. Nobody believes in GPOEM in a lot of centers. Why? Because the outcome is very weak. Because it's very difficult to objectivize motor dyspepsia, gastroparesis, scintigraphy, MRI. It's totally a mess. But at the end, there are some good clinical studies. On this study, the guideline should be based. This is the 100 email that we received by Jeremy Jacques. We did a clinical study, you need to give a clinical statement. And so we gave the clinical statement that any adenoma removed with ESD is not an overtreatment. Nobody can argue today that ESD is an overtreatment. Where is Alberto Morino? So yesterday Alberto Morino did a ESD on a 2 centimeter proximal granular LST with no risk of cancer. But it was not overtreatment because he minimized the risk of recurrence. This is the idea by Jeremy Jacques. And this is the first idea we did with the American Society on Bariatric Endoscopy, where for the first time we gave a clear indication on bariatric endoscopy. You can like, you can dislike. This is a clinical guideline based on clinical outcome. And this is the big success of Andrea, Marco, Benny, and his friends on the use of primary drainage for malignant cancer obstructing the biliary tree. Okay, so this is my final slide, but it's not my final slide. Data. Most of research will come from technical. Any center is involved in a lot of trials for technicality, but very few study on clinical outcome will come, and it will be this clinical randomized trial that will change forever the history of medicine. But I feel that both of the sources are extremely good. But then we come with a bed to collaboration, so where ESGE need to collaborate, and also Pradeep here is extremely active. So we need to collaborate basically on training. We can do whatever document we like, but if this is not training, this is zero. This is why, for instance, the Center by a Bed is so popular, because here people are trained, they do a lot of procedures, and the results are extremely good. There is a strong evidence, but you don't need a study to know that if you come here and you do dissection, you will become a good dissector. If not, you are dead. Can we improve training? This is the must for the future. For instance, artificial intelligence could help, and this is one software that tell you where there is the vessel, and then if you don't follow the software, a big bleeding can come. So what ESGE did for training, we would like to do a lot, but we just started 2 years ago with this academy that is our most successful intervention, where we have all the training module for any procedure, very similar to the American society, and this is other software that are available. What we also do is a lot of, but not a lot, we do hands-on training, and Lorenzo did a re-evaluation of all the simulators that should be used for training in the future. So it may be animal ex vivo, it may be in vivo, and here is where our society should work. What our society did very well was that we developed the curricula. So you come here to a bed, you say, I want to learn bariatric endoscopy, how should I train you? There are documents that they tell you step by step how you should train an endoscopy. This is true for bariatric endoscopy. This is true for ERCP and EUS, and this is done by Antonio and friends. And this is the curriculum we did again for ESD and bariatric endoscopy. Yeah. Okay, the final step, and here is also where all the centers should help us, is that we did innovation, we validated innovation, we did the training, but there is the need of someone who certifies that you can start finally doing your procedure, achieve the dream of your, Manolo is here. So, Manolo, who should do all the complex procedures that you do? Who certify? Is it the Spanish Society? Is it ESGE? Is it your center? Is it yourself? No, I can. What do I certify? So, certification. So this is the problem. Should we do a theoretical assessment? But probably yes. Who does? But maybe the Academy of ESGE. Can we do a hands-on assessment? Okay, we do. But do we need to come to Abed Center, to Manolo Center, to Andrea Center, or does ESGE centralize the center? I don't know, actually. And finally, there is a hands-on assessment. This is where ESGE cannot do anything. Here is where we need to collaborate. We need someone who take this trainee, let him do 5 procedures and say, yes, you are successful in your training. You can do your procedure. So the collaboration that Abed invited me to talk about, I see it mostly in training and in certification. Here is where we are naked. Here is where we cannot do anything by ourselves. Okay, so this was a very boring presentation, but what is not boring is that Manolo is always winning. The Spanish Society is always the first in number of abstracts. But if you want to listen to 3,000 abstracts about endoscopy innovation, you come to Milano. And I was clearly